good evening, all the aspirants present here. First of all, apologies for the all of this network issue. And today's topic is acute coronary care, which will be taken by Dr. Amrit Kaur, ma'am. She is a senior clinical fellow at St. George Hospital, London. Yes, ma'am, you can carry on. Thank you very much.
Thank you so much. Really apologies, guys. This computer is not my strongest asset. Hi, everyone. I can see we have a few people here, Akila, Omer, and hi to everyone I can't see on the screen. We'll try to keep this presentation interactive. Stop me whenever you want. This presentation is not just to present you the topic. This is made keeping in mind on how we use this care in ICU patients and how we use it for EDIC 1 as such. Remember, this exam is not a cardiology exam. This is an intensive care exam. So we only need to focus on the acute coronary care. We don't need the details of post-coronary care and long guidelines. So let's begin. This slide is just made not for the statistics, but to show you that ACS is responsible for almost 50% of the deaths responsible from cardiac causes. So that's a lot of percentage. And it is a significant 1.6 million hospital admissions. And most of them, more than half of them are because of NSTEMI and unstable angina. And less than 1/3 is from STEMI. Now, before we start, just a basic question to warm up and to just introduce ourselves. Let's start with the questions. So the first question is, what is the most common symptom of myocardial ischemia and infarction? Anyone who feels like answering it?
Fourth.
Amazing. Fourth, it's correct. It's retrosternal discomfort. Great. Second question, when would you give oxygen to a patient?
Less than 92%.
It's 90 actually on the guidelines. So close enough, 90%. Or obviously, if the patient is in respiratory distress, you would want to give it despite the saturation levels being normal. Next, what would be your time goal
10 minutes.
10 minutes.
10 minutes. Amazing. Correct. 10 minutes is great. Next, your primary treatment focus for patients with ACS. What do you want in your treatment?
Rapid reperfusion following STEM presentation.
Amazing. Perfect. The last one before we start. Which arrhythmia is the commonest caused by MI?
Number 3, ventricular fibrillation.
Amazing. Perfect. Now let's begin. Acute coronary syndrome. Keeping it the most basic, these are diagnosed on the basis of a patient coming to you with chest pain. Now we have to see if this is unstable angina, this is NSTEMI, or if it is STEMI. The first step you do an ECG. Your ECG shows ST elevation, so it is an ST elevation MI. It's sorted. The next step is if the ECG shows anything other than ST elevation, it could be a depression, it could be just T-wave inversion, it could be non-specific changes, or it could be an absolutely normal ECG. At that point, you have to decide if this is an unstable angina or an NSTEMI. What do you think is the next step to differentiate between these two?
Cardiac
enzymes.
Amazing. If the enzymes are elevated, it would be an NSTEMI. If the enzymes are normal, it would be an unstable angina. So basically, unstable angina is a diagnosis made by your history rather than any clinical investigation. The signs and symptoms. The first symptom is a chest discomfort. It is not pain, it's a discomfort. It could be tightness, it could be pressure, it could be heaviness, and it persists for a prolonged period of time, firstly, and it happens at rest. Discomfort can be associated with syncope or symptoms of heart failure. It is not only in the chest, it could be in the back, neck, jaw, arm, shoulder, and one of the questions I've seen on EDIC 1 exam, it's an epigastric pain. So to be mindful that it could be an epigastric pain. The person can also present with symptoms other than pain, where pain is not the predominant symptom. It could be dyspnea, it could be diaphoresis, it could be dizziness, it could be nausea, and it could be vomiting. So especially the elderly patients who come in with syncope always think of MI as one of the causes for syncope or collapse. And we all know women, elderly, and patients with diabetes, they are less likely to experience chest pain as a symptom. Now, this slide is crowded, but what I want you to understand from this is patients who come with chest pain and the differentials, they can be life threatening. So do not think chest pain as MI. Always keep your options open to the life threatening differentials, which include aortic dissection and pericarditis. Now, it's very simple. How would you rule out an aortic dissection? You have done the ECG. What should be the next step to rule out an aortic dissection? Simple step, which would also help you rule out your pneumothorax and pneumonia. What investigation would you do?
Chest X-ray with a widened mediastinum with
Amazing. Yeah, great. And the widening of the mediastinum could be because of the bleeding from the aortic dissection. So chest X-ray would help you rule out aortic dissection. Pericarditis can be ruled out by your typical ECG findings of pericarditis. Pneumothorax, pneumonia, you see it on the chest X-ray. Pulmonary embolism, the chest X-ray will be absolutely clean. You will have a patient who's hypoxic, who can be hypotensive, who could be dyspneic, but your X-ray is clean. So you should think of pulmonary embolism as one of your differentials. GI symptoms, these are not life-threatening, but cholangitis, cholecystitis, a female, 40, fatty female can come with biliary manifestations. Keep in mind. Another one of the questions and important clinically is herpes zoster. So whenever you're examining the patient, whenever you're applying chest ECG leads on the patients, always think of herpes zoster as one of the differentials, especially because you're preparing for EDIC 1. When you come to Europe, patients come from nursing homes, not looked after very well. Herpes zoster is one of the important differentials for chest pain. And then, of course, the list goes on, but the life-threatening ones should be ruled out quickly in a timely manner. Now, anginal equivalent syndromes. We know patients who have ACS, but they do not complain of chest pains. They can come off atypical pain, which is not retrosternal. It could be dyspnea, it could be diaphoresis, MSS, as we read in the previous slide. It could also be an altered pain perception where they have pain, but they can't tell you that they're experiencing pain. These are the elderly patients, the nursing home patients, patients who have long-standing diabetes mellitus. And remember, in 10 to 30% of the cases, the most common anginal equivalent syndrome is dyspnea, which is because of pulmonary edema. Okay, my slide has stopped moving now. The pain sometime, have you seen the slide has moved? Can you see the next slide?
Yes, we can.
Okay, thank you. The pain can be atypical in the sense it can be in the epigastric. We've seen it can be in the jaw, arms, even in your wrists and interscapular region, in your back region. It could be perceived as a burning pain or a pressure pain. Very rarely, it is a sharp or a stabbing pain in nature as we normally think. And then, of course, there are other manifestations, including nausea and vomiting. Okay. Now, this we have already discussed about. ST elevation, MI would have an ST elevation on the ECG. You send off troponins, but you don't wait for the markers to come back before acting on the patient. An ST elevation would have ST depression, T-wave inversion, and elevated enzymes. And unstable angina would have normal cardiac enzymes. This we have discussed. This is briefly the pathophysiology of ACS, and in the next slide, I would tell you why it is important to know about this. It all starts from a plaque, which is a vulnerable plaque. Why it is vulnerable is because the cap of it is quite thin and it has a big lipid pool in it. Now, this plaque can rupture, and then the prothrombotic molecules are exposed, and then a thrombus forms because it's prothrombotic. If it transiently occludes your artery, it would cause angina. If it completely occludes your artery, it will cause a STEMI. And if it's just a partial clot, it would cause an unstable angina or an NSTEMI. Now, this slide is important because of our therapy that we use. The clot that forms has two pathways. It happens because of platelet adherence and activation, which leads to a white thrombus formation. And then the main pathway, that is your coagulation pathway activation, which leads to involvement of your thrombin and fibrin and eventually a red thrombus formation. And this is important because our two major therapies are antiplatelets, which act on the white thrombus. These are antiplatelet agents. They can be aspirin and ADP receptor antagonists. And the fibrinolytic agents, they act on the red thrombus, but they do not act on the white thrombus. And that is why we should be mindful what therapy we are using and what pathophysiology it is acting on. If we come back, this slide, why the plaque ruptures is because of increased adrenergic tone and acute hemodynamic stress. So when a patient comes to us, it is worthwhile knowing that decreasing the adrenergic tone, decreasing any factor that reduces the oxygen demand is helpful in improving the coronary perfusion. So hemodynamic stress, increased adrenergic tone, we should be tackling apart from giving definitive therapy. And also, because your plaque was rich in lipid, so lipid lowering agents, your statins, should be used. They not only lower your cholesterol levels, but they also have pleiotropic effect. So this is one of the questions from EDIC 1 about your statins. And also remember, it takes hours before a transmural MI is developed. And therefore, when we say time is muscle, we have time. We should take all the steps possible to decrease the myocardial oxygen consumption. So this is about your pathophysiology. Any doubts so far? Should I keep going forward?
Yes.
Okay, I take it
Yes,
as
you
a
can.
yes. Okay, thank you. Just from this slide, just one point for you to take is when there is myocardial necrosis, that is the death of your myocardium, it is called as myocardial infarction. Before that, it is angina and STEMI, but with the death of the cells, with the necrosis, is when you call it myocardial infarction, just for symptomatology. This we have discussed already, how to differentiate between these three entities. Now, your risk factors, we know family history, smoking, obesity, again, obesity, old age, hypertension, diabetes, these all are the risk factors. The non-modifiable risk factors, gender, more common in men, age, family history, and HIV. These are the non-modifiable risk factors. All the modifiable one, I think we all know about it. Gender differences, when you compare females to males, they present obviously MI later in life after menopause, but they have poorer prognosis and high morbidity. They're more likely to die in the first week after MI, and they have higher rates of unrecognized MI. Diagnosis can be made clinically. We should have a rise and a fall in the serum level of cardiac markers. When you have a patient who comes with a symptom of MI and you do an ECG and you look at the ECG and there are ST or T wave changes, a new left bundle branch block, and you send cardiac markers, it is important to interpret cardiac marker as a level that is either falling or increasing. If you have a cardiac marker that is high, but it remains constantly high, it tells that this is a chronic problem rather than an acute problem or a new MI. So you have to see cardiac marker as a trend rather than one absolute value. And then imaging evidence is not required to make the diagnosis, but it is a useful tool to have a regional wall motion abnormality detected on your echo. Your STEMI patients, the symptoms, the basic signs in STEMI would be because of a left ventricular compromised. It would be a pulmonary edema, which would give you crackles, a jugular vein distension, a fourth heart sound, a third heart sound, and a pericardial rub may be heard. So we have seen.
Can I just ask before you go on?
Yeah.
In terms of the cardiac markers, between the top T and the top I, which one should we be using, and what's the difference?
In the ESICM and your European Cardiology Society, they have not mentioned any preference. They just say cardiac troponins. And
Okay.
I think T and I both are same because they're cardiac specific. The third isoform is not cardiac specific. So T and I both should be good. Yeah.
All right. Thank you so much.
No problem. When we come to STEMI, you've done a 12-lead ECG, and this numbers, you don't need to memorize these numbers, and we'll come to a slide which defines more precisely in which leads we talk about more than 1 millimeter elevation and in which leads more than 2, but you don't have to, they don't ask about the numbers, but you should know a new left bundle branch block and an ST elevation in 2 contiguous chest leads is STEMI. That is the feature of STEMI. Now this slide, it looks a bit crowded, but it's a very important slide for your EDIC 1 and then even for your EDIC 2. Normally when we talk about MI, we talk about anterior STEMI, inferior STEMI, and posterior STEMI, which leads, I'm sure you all know, inferior STEMI is 2-3 AVF. Your anterior leads are V2, V3, V4. Your lateral leads are V5, V6, and 1 AVL. You should also know the branches that are occluded to give you that area of involvement. Is there anyone who's not familiar with this slide or wants to go into detail of this? I assume we all know about the areas and their arteries. There are 2 specific areas of infarction I want to bring your attention to. One is the posterior wall MI and one is the right ventricular MI. I think anterior MI is very clear. It is your anterior chest lead. So it is V2, V3, V4. Inferior, we all know it's 2-3 AVF. And lateral also, we are very clear that it's 1 AVL and V5, V6. We don't want to go into the details of anterolateral, inferolateral, and septal, so I'm leaving that part. But the true posterior and right ventricular, these are tricky. They come in your EDIC 1 and they come in your EDIC 2. Anybody who would tell me how you diagnose a posterior MI from your ECG?
So in V1, you'll have tall R waves. In V1 and V2, the ST segment will be flattened, horizontal,
Yeah.
and the R wave will be broader
Yeah.
in V2 as well.
Yeah,
And that will
great.
be, yeah.
And how do we diagnose it further then?
So we add in additional leads. We do on the left side of the patient, below
Yeah.
the scapula, V7, 8, 9.
Yeah.
And those leads will show the reciprocal changes as ST elevations.
Amazing. Perfect. This is absolutely perfect. And when you do it in clinical practice, you know how you have ST depression in V1, V2, V3. Just turn your ECG upside down, look it from the behind, and you will see ST elevation in V1, V2, V3 without even doing V7, V8, V9. But that is not the clinical answer they are looking for. I want you to have a look at this ECG. This is the posterior wall MI. As you very correctly said, there is ST segment depression in V1, V2, V3. And then we apply posterior leads, as you correctly said, on the left side of the patient. These are called V7, V8, V9 leads. And then you can see ST elevation in the leads marked V7, V8, V9. So this is your posterior wall MI. For posterior wall MI, always think it could be either a circumflex artery or a right coronary artery. More commonly, it's the circumflex that causes your posterior wall MI. Then if we come back to our this slide, for the right ventricular infarction, this is really important because it's a separate entity. It is one of the MIs that is notorious for causing cardiogenic shock, and where your nitroglycerins are absolutely contraindicated. And one of the MIs where you actually want to give fluid to the patient rather than just starting on inotropes. This is important to diagnose. You'll have an ECG where you will have ST elevation in your 2-3 AVF. It's your inferior MI, but you want to rule out if there is any involvement of your right ventricle. So you apply a V3R and a V4R lead, which is on the right side. And if there is elevation in these two leads, it means your right coronary artery is involved. It's a right ventricular infarction. Is everyone okay with this slide? Should we move forward? Okay. Now, this is a simple ECG strip which shows the progression. I'm not sure how important it is for your EDIC 1 exam, except that in hyperacute stage, you might get tall peaked T waves. These are signs of a hyperacute MI that is going to develop into an MI. So not to miss your hyperacute stage. It occurs very early, within 30 minutes to hours. And then also there is loss of your R wave on this lead. This is ST elevation, we all know in the acute stage, but more importantly, never miss your hyperacute stage. The early phases, it is the progression of your infarct. So the T wave starts to invert, and then eventually the Q wave appears in your whole infarct. Now, the recommendation from your ESICM says your ECG should be done and interpreted by your first medical contact within 10 minutes. This is your EDIC 1 question. Second question is your ECG monitoring should be done on a device that has a defibrillator capacity, because we've seen in our question, VF is the most common arrhythmia, and therefore you should always have a defib ready. Third one is for patients in whom you suspect a posterior wall MI. Because of the circumflex, always consider V7 to V9, because when you do this ECG and you just see ST segment depression, do not rule it out as an N-STEMI. It can be a STEMI. Do your V7 to V9 to make sure you're not missing on your MI. And then in RV infarction, we should get V3R and V4R. This is the slide which tells about a lot of numbers. I don't think they ask about these numbers, but just to go through it, the ST elevation will be when your two contiguous leads will have more than 1 millimeter elevation in all your leads, except V2, V3, where this elevation is higher to 2 millimeter. And then the NST elevation would have your ST segment depression, T wave inversion, or if you see a T wave which looks normal now, but on the previous ECGs, they were inverted, they are also considered abnormal. This I've spoken about, but just to read with you guys, depression in V1, V3 is suggestive of posterior MI. Always do V7, V8, V9. It is reflective of your circumflex occlusion. In patients in whom you suspect a right ventricular infarction, V3 and V4R should be done. And one of the other clues that it could be a right ventricular infarction is that your leads AVR and V1 may exhibit ST elevation. Now, your lead AVR is a universally negative lead. Any elevation in AVR is a very notorious MI. It could either be a right ventricular infarction, or it could reflect a left main coronary artery disease. So any elevation in your EVR, be very careful. This we have seen. This is your posterior wall MI, your posterior leads. And we have seen this horizontal ST depression in posterior MI, tall R waves, as you said, in V1 and V2. This was all about ECG. I think there should be a separate class on ECG because it's an extensive topic both for EDIC 1 and EDIC 2. But if there's anything you want to ask from the slides that we have seen, I'm happy to answer. Sorry? Should we start the cardiac markers now? Okay. Now your cardiac troponin, the cardiac troponin T and cardiac troponin I, these are exclusively expressed in the cardiac myocytes. The most important part of the cardiac troponins are they start rising in 4 to 6 hours, and then they peak in 24 hours. So this red line that you see is your troponin. It starts rising within 6 hours, and you see within 1 day, it peaks and then it starts to decrease, but it takes a good 14 days to come back to normal levels. So when you send your troponin level at 0 hour, it may come out to be normal because it starts to increase at 4 to 6 hours. So the second level should always be sent at hour 3 and then at hour 6. CKMB, it is less sensitive and less specific than troponin because we know some of the CK exists in muscle and brain subunits. So it could be increased even in trauma, including brain trauma and surgeries. It, like cardiac troponin, it also starts increasing within 4 to 6 hours. It also peaks within 24 hours, but it remains elevated only for 72 hours. So if you look at this slide, the CKMB is the first one, the yellow one here, and it comes back to normal. So the advantage of CKMB is in reinfarction. Come to the advantage slide in a second. The recommendation from your European Society says the troponin I and troponin D, they are the preferred biomarkers. Now we have high sensitivity troponin assays that are available, and they should be used in routine practice to diagnose your MI. Sorry. Was anyone saying anything? Okay. And then send it at 0 hour and then repeat it at 3 to 6 hours. What is written in this crowded slide is your troponins and your cardiac CKMB levels. They basically tell that there is a myocardial injury, but it does not tell you what is the underlying pathophysiological mechanism. Troponin elevation wouldn't directly mean that the patient has MI. There could be n number of reasons why troponin could be increased. It just signifies that there is a myocardial injury. Also, higher your level of troponin in a patient of MI, higher the chances that the thrombus is bigger, and the ischemic myocardium or threatened myocardium is also bigger. So it is a very strong predictor of risk. And be mindful of the situations in which your enzymes can be elevated. These are the conditions most commonly that we come across are shock and sepsis, especially in ICU patients. Troponins can be elevated. It doesn't mean that the patient has an MI. It could even be increased in an obstructive shock, distributive shock, myocarditis, heart failures, pulmonary embolism, renal failure, especially your troponins, they are excreted from your kidneys. Your trauma patients will have high enzyme burden, burns, rhabdomyolysis. And patients who come after extreme physical exertion, your question could be framed around a marathon runner who's come after a marathon and has his troponins elevated. Doesn't necessarily mean he has an MI. If we look at the advantages, we know the troponins, they help you in risk stratification. They have very good sensitivity and specificity. And because they are elevated to 14 days, so they tell you that there had been an MI in the past 2 weeks. And when you reperfuse, they start to come down. So you can even see the success of your reperfusion from your troponins. CKMB, their advantage, the most important advantage is they help you diagnose early reinfarction. We know the disadvantages, the troponins, they take at least 4 to 6 hours. So do not believe in the first value you get, always send the second level. And as per your guidelines, send it at 3 hours and 6 hours. The CKMB, the drawback we know, it can be increased in diseases or conditions where you have injury and skeletal muscle disease. We have seen this slide. The other point is cardiac imaging. It is not important to make diagnosis, but it is a very useful tool. We do a bedside echo. You can see regional wall motion abnormality and LV dysfunction. More importantly, it will help you diagnose other causes. It will help you rule out MI if the patient has come with chest pain and has a LV thrombus, a severe aortic stenosis, a HCM, RV infarction, an aneurysm, a pericardial effusion, a tamponade. It will help you rule out MI and help you diagnose the other diseases. Also remember, when more than 20% of your transmural myocardium is involved, it is then you would start to see regional wall motion abnormalities. So your echo can be absolutely normal as well. When you perform an echo, how do you know that this is an ischemic heart disease, like this is an acute condition? You will have segments of normal contractile myocardium, which are mixed with abnormal contractility. So it will not be a global regional wall motion abnormality. You will get RWMAs in the areas where your coronaries are affected. But instead, if you see a completely dilated left ventricle and an akinetic septum that's not moving at all, and a big dilated LV, it means that ischemic heart disease, it's an ongoing, it's a chronic thing. It's been chronically hypoperfused. And eventually, your gold diagnosis is the cardiac MRI to differentiate ischemic from non-ischemic MI. This is for late presenting MI, not for acute, obviously. This slide is just to show you that within few hours, like 1 to 2 to 4 hours, you have some heart muscle damage after MI, and moderate amount of muscle can be salvaged. But as time passes by, especially after 12 hours, there is not any muscle that you can salvage, and reperfusion is not routinely recommended if the patient is asymptomatic. Are we clear till now?
Yes, we are. Thank you.
Okay. Now we can start talking about treatment. Now we have diagnosed our patient. Our patient is in the CCU setup. Another important question is, where do you treat the patient? When you see from ED, they go to either a cardiac, a CCU, or a high dependency unit, or an ICU. And especially in EDIC 2, they give you 1 point in saying that they are triaged to a proper treatment area in the hospital. These are the 3 things that are suggested by the ESICM. You should have a non-invasive blood pressure monitoring, a pulse ox, and a continuous ECG monitoring on the patient. Once you have a patient, you've diagnosed. Now the immediate treatment would be, obviously, we have done an ECG. We repeat it. If your first ECG did not give you a diagnosis, repeat it after 15 to 30 minutes. Start giving oxygen if your patient is hypoxic or in respiratory distress. Put a big cannula in the patient. Try not to use the right arm because they use it for angiography. Use a left arm. And then send your biomarkers at 0 hours. And then apart from biomarkers, this is another question. You also need to send biochemical functions, including renal function, and hematological workup, including coagulation. Nitrates. The only use of nitrates in MI is for pain control. That's it. If a patient is pain-free, we don't use nitrate. Nitrate is used just for analgesic. You don't need to remember the dose. We initially use it sublingual. If your patient is able to accept sublingual, give it for 3 doses. If there is not adequate pain relief, go to IV nitrates. IV nitrates, there is no specific high dose that they have or the higher end of the dose that they have suggested. Keep up titrating till the pain control is achieved. Once you have the pain control, the nitrates are removed. IV nitrates, of course, are more effective than the sublingual. Remember the side effects, it can cause hypotension, and sometimes because of the Bezol-Jerish reflex, it can also cause bradycardia. We all know normally nitrates cause tachycardia, but sometimes it can even cause bradycardia. Do not use nitrates if a patient has previously used a phosphodiesterase inhibitor in the past 48 hours. And if you think the patient has a right myocardial infarction, right ventricle, or an inferior MI, do not give nitrates because it will cause severe hypotension. Next, for pain control, morphine. Why do you think pain control is important?
It
To
will
decrease
decrease the
the
cardiac oxygen demand.
Amazing. Perfect.
Tachycardia.
Yeah. Tachycardia, pain control, anxiety, everything comes down.
adrenergic stress.
Yes, adrenergic stress, correct. And so we use morphine. We can use it every 5 to 15 minutes. It's very commonly used for pain control, and it's a very good agent. Always be mindful, morphine can cause vomiting, so always give anti-sickness. Second, morphine, because it's an opioid, it can decrease the absorption of your aspirin and clopidogrel that you give. There is no evidence against it, but something to be mindful of. The most important treatment actually is aspirin. The dose is important. Remember, it's 160 to 325. It has to be chewed and swallowed on arrival, not taken with water, but chewed. And then after that, a daily oral dose of less than 100 milligram is given, and it has a mortality benefit. So that is important to know. The other agents, which are your P2Y12 receptor blockers, clopidogrel, ticagrelor, prasugrel, they are used along with aspirin. In your European Society of Cardiology recommendations that have come in 2023, there is a lot of literature on when to use prasugrel, when to use ticagrelor or clopidogrel, but I think it's not important for EDIC 1, so I have not covered it. But feel free to read if you want. The guidelines are quite clear and they are quite compact as well. The other important agent is your beta blockers. We should use beta blockers if our patients are hemodynamically stable within the first 24 hours. They should be started as early as possible. But obviously, if your patient is hemodynamically unstable or in cardiogenic shock, wait till the patient recovers and then start orally and gradually build up to the maintenance dose. If the patient is in frank pulmonary edema, we would treat it with CPAP, IV furosemide, and upright posture. Now we come to reperfusion therapy.
Ma'am, why beta blockers in MI, ma'am?
Yeah. To control the heart rate again.
Okay.
Yeah. So the effect of beta blocker when we start and the maintenance dose is seen as per the heart rate. And the maintenance, usually they say we try to maintain the heart rate between 50 and 60. They do
Okay.
not affect the blood pressure as much as they affect the heart rate. And this is again to control your sympathetic drive.
Okay.
Now, reperfusion therapy, we know it can be in the form of an invasive therapy, that is your PCI, or it could be in the form of fibrinolysis. So let's go through this slide together, everyone. Read it, because this is something which you need to learn rather than need to understand. Reperfusion therapy is indicated word by word in all patients, and we are talking about reperfusion therapy, not which reperfusion therapy. So it is indicated in all patients with symptoms of ischemia of less than 12-hour duration. So a patient with chest pain within 12 hours and persistent ST elevation. We are talking in this slide about your ST elevation MI. So a patient who came within 12 hours and has an ST elevation has to go a reperfusion therapy. A primary PCI strategy is preferred over your fibrinolysis. Which therapy is preferred when? We'll go through a good chart together. But if you can timely perform this therapy, that is, the paramedic usually are the first people who diagnose MI, and if they think they can take the patient to a primary PCI center, and PCI can be done within 120 minutes, within 2 hours. In that scenario, primary PCI is preferred over fibrinolysis. But if you think you cannot do a PCI, you don't have a cardiologist, we don't have a PCI center, In that scenario, fibrinolytic therapy would be preferred. Is that clear? Or have I confused you?
Clear, ma'am.
Okay.
Clear.
It's clear. If there is a
Okay.
delay
Yeah.
to primary PCI, and within 12 hours, you will do the fibrinolysis. If you
Yeah.
can
And your
get to the
time period.
center
Yeah.
with the center that has it, and you can get there within 2 hours, then
Yeah.
a primary PCI is preferable.
Yeah. So it is not about getting there in 2 hours. It is about your wire crossing in 2 hours. So now this is because this is an EDIC exam. This is European thing we are talking about. So the paramedic calls the PCI center. We have a patient who has an ST elevation MI. Can this patient get on the cath lab table and have the wire crossed in 2 hours? If they say yes, the patient comes to a primary PCI center. If they say we can't do it, we don't have capacity, we don't have a cardiologist, it's going to take more than 2 hours, they will go to a center who can reperfuse the patient using a fibrinolytic. As simple as that. Right? This is the second line. If the timely primary PCI cannot be performed, then your fibrinolytic therapy is recommended. Now, if you have a patient who doesn't have an ST elevation MI, but the symptoms are ischemic, he has a chest pain, and it's an NSTEMI basically, or an unstable angina, but he has hemodynamic instability or is in cardiogenic shock. They have recurrent or ongoing chest pain, which is refractory to medical treatment. They have life-threatening arrhythmias or cardiac arrest, mechanical complications of MI, acute heart failure. Their ST segment and T wave changes are dynamic. In these cases also, we do a primary PCI. So this list is for the patients with NSTEMI. And if your STEMI patient has come after 12 hours and is symptom-free, you don't do a PCI. But even after 12 hours, if your patient has symptoms of ischemia or is hemodynamically unstable or is having arrhythmias, we still do a PCI even after 12 hours. Is that okay? Okay. Again, this is from your guidelines. If you want, should we go through each point together? Should we do that? Or you guys can take turn and read each single point. This is an important slide. This comes in your EDIC 1 exam in the form of your MCQ. So we can read it and see if there's any doubt. It's very straightforward though.
I think let's read it. So when
Let's
you
read
revise,
it. Yeah.
yeah.
So reperfusion therapy, this is about STEMI basically, is recommended in all patients who have STEMI and have come to us within 12 hours, do a PCI. Primary PCI strategy, over fibrinolysis. If the anticipated time from diagnosis to PCI is less than 2 hours. If you cannot perform it within 2 hours, fibrinolytic therapy is recommended. Rescue PCI. What's a rescue PCI? It is when you have thrombolized a patient, but the ST segment resolution is less than 50%. In those cases, or if the patient still feels anginal chest pain or is hemodynamically unstable, in that conditions, even after your fibrinolysis, you take the patient for PCI. That is called a rescue PCI. Now, in patients who have a STEMI and have come to you after 12 hours, you should do a primary PCI if the patient the symptoms are suggestive of ischemia, he has an ongoing chest pain, is hemodynamically unstable, and again has arrhythmias. What if a patient comes to you after 48 hours and is hemodynamically stable? You do not do a reperfusion therapy. So our guidelines basically stop at 48-hour onset. Till 48 hours, we are considering. Till more than 12 hours, we are doing. Between 12 to 48 hours, we considered. But after 48 hours, a patient who was hemodynamically stable, we do not do reperfusion therapy. This is all about PCI. And I would suggest in questions, when confused, always PCI is the answer. Very rarely is fibrinolysis the answer. This is again for NSTEMI, and if you read the in entirety, the answer that comes out is in NSTEMI patient, the answer is also PCI. The only point they ask in exam is when you have to do an immediate PCI versus an early, that is within 24 hours. That depends on your risk stratification. So it's important to know patients who have very high risk criteria. So on ECG, you have seen it is an non-ST elevation, and you stratify them according to the high risk criteria. If they have any of the following, if they're hemodynamically unstable, if they are in cardiogenic shock, they have persistent chest pain despite giving medical therapy, and the same points: arrhythmias, mechanical complications, acute heart failure, cardiac arrest, recurrent dynamic STT changes, their ECG keeps changing, they should be taken for an immediate PCI. But if you have a patient who has a confirmed diagnosis of NSTEMI, the ECG changes are dynamic, and their GRACE score, I would suggest just remember the name GRACE score. We don't have to go into the details, is more than 40. But none of these clinically complicating features, they can be taken for PCI within 24 hours. It doesn't need to be an immediate therapy. Is that okay?
It's okay.
Now, I'm sorry?
I think it's okay. Thank you.
Okay, yeah. So fibrinolytic therapies, we all know the indications and contraindications for thrombolysis. Active bleeding is an absolute contraindication. These are simple. If you have neurosurgery within 6 weeks, trauma, major surgery within 2 weeks, these are absolute contraindications. We do not thrombolize the patients. Relative contraindications would be a very high blood pressure. This is commonly seen, more than 200 by 110, an INR of more than 2 to 3, and the use of treatment dose anticoagulants, not prophylactic, but treatment dose anticoagulants. We try not to thrombolize these patients. And obviously, this is for STEMI. We do not thrombolize patients with NSTEMI. So ST elevation and left bundle branch block. We need to thrombolize these patients. When you have thrombolized the patient, remember, you have to monitor them for 90 minutes, and the reperfusion should be achieved within this time frame. By reperfusion, we mean the symptoms of chest pain should vanish, and second, more than 50% of your ST elevation should resolve. If there is still more than 50% of ST elevation, it means this is a failed thrombolysis and they need to go for a rescue PCI. After you have thrombolized the patient, still they need to go for an angiography to see if the occluded vessel has been completely opened up. But if they have high risk features, they need to go immediately after thrombolysis. These high risk features, I think this is something that we've seen in previous ones, your features of cardiogenic shock, that is your systolic blood pressure is less than 100, your heart rate is more than 100. If the patient has an ejection fraction of 35%, this is a recurrent MI, it was a new onset left bundle branch block, and it was an extensive ST elevation MI. After thrombolysis, immediately refer them to a PCI center. These are the commonly used agents: alteplase, reteplase, and tenecteplase. We have read about PCI. The PCI has mortality benefit. So we should know that it gives you a mortality advantage. The same slides. We don't obviously need to know about stents, but just remember, when we do an angiography, we can either do balloon angioplasty or use stents. There is no mortality benefit between these two, but the study have shown that if we use stent as compared to balloons, there is improvement in the revascularization and less angina in stented patients, but no mortality benefit again. There are two types of stents that you can use. You can use a bare metal stent or a drug-eluting stent. These are again some common times, but I would rather discuss this slide when we talk about times. So line by line, first medical contact to ECG should be less than 10 minutes. Less than 120 minutes to reach to a PCI center and have the wire crossed. If the maximum time from STEMI diagnosis to wire crossing in patients presenting at a primary PCI hospital. This means that the patient who comes to the PCI hospital directly by himself, we're not talking about the paramedic involvement. If they come directly and they have an ST elevation MI, they should have the wire crossed within 60 minutes. If the patient comes from some other hospital, the wire should be crossed within 90 minutes. If you are doing fibrinolysis, it should be started within less than 10 minutes. Observe them for 60 to 90 minutes to see if your fibrinolysis was successful or failure. And then after your fibrinolysis is successful, within 24 hours, you should do an angiography. We've discussed about our aspirin. It reduces mortality. It has a mortality benefit. Clopidogrel, prasugrel. Anticoagulants. Heparin is used when undergoing angiography, and this is to diminish the reocclusion after successful reperfusion. Anticoagulants can be used in the form of unfractionated heparin, enoxaparin, fondaparinux, or bivalirudin, but there is no recommendation on which is better or which to use. It's worthwhile knowing the name of the anticoagulants. Then you have your antithrombin agents, your GP2B3A receptors. Their role is uncertain. They do not ask about details or the doses of these agents, but worthwhile remembering the name of them just to know that these are the antithrombin agents. I remember them as T for tirofiban, E for iptifibatide, and A for epsiximab. So these are our antithrombin agents. And we've read about nitrates, about beta blockers. ACE inhibitors and CCBs, they are not indicated. All patients should have statins. This is a recommendation. We have read about the, till here we finish the STEMI and its management. Any doubts?
Just one question. When you say rescue PCI, it confuses me. I'm sorry if you can just briefly tell about it.
Can you repeat your question again?
I was saying rescue PCI. I mean, briefly you mentioned it, but it confuses me.
Okay,
Rescue PCI,
yeah, sure.
Is it after fibrinolysis?
Yeah. So when you have thrombolized a patient, either because thrombolysis, we know it's a second line management. So when you cannot take your patient to a primary PCI center within the time frame, you thrombolize the patient. And then you observe the patient for 60 to 90 minutes. By observe, we mean for the chest pain, for hemodynamic stability, and for ECG changes. Your ST elevation should resolve by more than 50% for your thrombolysis to be successful. If the ST elevation has not resolved by more than 50%, or the patient still complains of chest pain or starts to become hemodynamically unstable, it is called failed thrombolysis, and the patient has to go for a rescue PCI. So it's not a primary PCI, it's a rescue PCI. So you're rescuing the patient after thrombolysis, basically. Is that any clear? Was that clear? I'm sorry.
Oh, it is absolutely clear. Thank you so much.
Okay. So here we finish our STEMI. Just very briefly about NSTEMI patients. For non-ST elevation MI, majority of your questions come around risk stratification. You know how to diagnose an NSTEMI and you know how to diagnose an unstable angina. When a patient comes to you, you have done an ECG, you've sent off the markers. If your markers are positive, you say this is an NSTEMI. But if your troponin was negative, remember we repeat it after 3 hours, we repeat it after 6 hours, and then if they start to come positive, it again is diagnosed as NSTEMI. In NSTEMI, what they want to ask you is, if the patient has a high risk, which I'll talk about in a while, we admit the patient to high care against. But if it's a low risk patient, we discharge these patients home and call them at a later date, like an elective angiography or a stress testing, depending on the symptoms. But not all the patients with unstable angina or NSTEMI need to be hospitalized. The patients who have high risk, these patients, if you read this line, these are referred for angiography to determine PCI or surgery, and they are admitted to cardiac, to the coronary unit or high dependency units. These high risks are again same as that we previously discussed. These are patients who have prolonged or more than 10 minutes of ongoing chest pain or discomfort. Their markers were elevated. Their ST segment depression was significant. It was more than 0.5 millimeters. They're hemodynamically unstable. They may have VT, they may have syncope, they have LV systolic function that is less than 40%, and they have come with a recurrent MI. These are high-risk patients. We admit them and then we treat them. We do an angiography and then we decide whether they go for a PCI or whether they go for a CABG. Is this slide clear for NSTEMI? Okay. Then we can have intermediate factors. Rather than learning about the intermediate factors, which means that obviously the patient needs to come in, needs to be admitted, and needs to have an angiography, just remember patients with low risk NSTS. These low risk patients who do not have high risk or intermediate risk factors, this is a bit confusing. Sorry about that. Patients with intermediate risk factors, same, whose chest discomfort or pain is persisting, who have a previous MI, who have history of hypertension, family history, active smoking, hyperlipidemia, who are diabetics, who are prior using aspirin. These patients are basically intermediate. They define as who do not have criteria for high risk, but they still have certain intermediate risk factors like hypertension. I'm sorry, I'm not sure why this slide is moving. But they have certain risk factors like hypertension, previous MI, but with an ejection fraction of more than 40%. Their chest discomfort happened, but it has stopped. But it did happen within past 48 hours. They are elderly patients. These all are intermediate patients. So your high risk and your intermediate risk patients need to be hospitalized. They need to go to the high dependency area. They need to have an angiography. Any patient who just had a one-off chest pain, who has none of these features, does not need to be admitted. They can come on an OPD basis, have a stress testing or a 24-hour ECG, keep a low threshold, and then decide on an elective basis if they need a further stress testing or angiography. But they don't need to be in the hospital is the main key point of this slide. In discharge. Are we clear on the management of NST elevation MI? Can I proceed further now? Okay. Just to let you know, there are a few scoring systems that we use. We don't need to remember the points, just remember their name. We have TIMI risk score. It is separate for your NSTEMI and STEMI. Just remember the name. You have GRACE score, you have TIMI score, and you have Phillips classification. 3 classification and scoring systems used for risk stratification. We have read about the management. The management is the same even for NSTEMI. It is nitrates, beta blockers, morphine, antiplatelet therapy. Nothing is different. This is the class 1 level of evidence for patients with STEMI who should have an angiography. And this is basically what we have read before. A patient in shock, a sustained VT, recurrent angina, elevated enzymes, new ST segment depression. So basically all your patients with STEMI are level 1 indications for PCI. Now, this is a slide mentioning about the complications of MI, the most important being, the most common being ventricular fibrillation. Apart from that, low ventricular function, cardiogenic shock, right ventricular infarction, pericarditis. Pericarditis keeps causing pain, so it's an important complication. Thromboembolism, left ventricular aneurysm, sinus bradycardia, your various blocks, your various arrhythmias can happen from MI. Anything that was not clear? If you, I think the STEMI slide might not have been very clear. If you want, I can go through it again. Or anything else you want to ask? Are we still connected?
Yes.
Yes, we are. If there's a question where we
Yeah.
have
Is
to
there anything
choose
you want
between,
to? Yeah.
if there's a question where we have to choose between trop I and trop T, uh, is there any, priority?
Sorry, priority on what?
If a question mentions both troponin I and troponin T, should we pick one, or it's unlikely to have a question like this?
I don't think so, because not in your ESICM, or neither in your European Society of Cardiology have they mentioned any one over the other. So I don't think so. There would be a question about either one of them. And now, because there's an increasing trend towards highly sensitive troponin, it doesn't even mention either it's troponin T or I, it's just highly sensitive troponin, HS, cardiac troponin. So I don't think so troponin T or troponin I would be a question. I haven't come across it in the EDIC 1 questions. You
Great,
can be
thank you.
definitely asked about highly sensitive cardiac troponin. That can be measured either as a point of care. When the patient comes in A&E, they have their own point of care machines like ABG machines. So you can either test it on those point of care machines that give you a really quick result, or they can be sent to conventional labs. But the recommendations say we should measure it in the lab because it's more specific and sensitive rather than point of care. So that can be a question because it's a new thing, but I don't think so. The troponin T or I can be a question, would be a question, honestly. Apart from your ESICM module on acute MI, there are really good ECGs on a gallery of ECGs given in the ESICM. That's a good gallery to go through. They are simple and very properly explained. Do go through them. And another thing I haven't included here was type of MIs. We know we have 5 type of MI. Just go through them. That can be a question. Anything else I can help with? Has any one of you taken an EDIC 1 previously? Or all of you giving it for the first time?
First attempt.
But the EDIC 1 modules, when you take the subscription for EDIC 1 exam on ESICM, the questions that they give in that exam modules, they ask very similar questions in the exam. And my advice to you is don't try to think too much. We try to bring a lot of our clinical experience into it. They're straightforward questions, and they want you to know the basics of most things, and we tend to skip the basics, like this question, where you treat the patient, the triage, the risk stratification. These are really important when you want to keep a patient in the hospital, when you want to discharge the patient, when you want to treat the patient as an emergency PCI, I'm talking about NSTEMI, and when you want to treat the patient as an immediate, not immediate, but can be done actively, that is after 24 hours. These kind of questions are really important. Or try to read and revise risk stratification and triage before you go for the exam. Those are important bits, because from our Indian ICU perspectives, we don't think about that too much, but those are important topics there. And your ECGs, they are important. They normally don't ask about localization of the coronaries in EDIC 1, but still to diagnose it as posterior or right ventricular or inferior, read about them. They are potential questions.
Recently, I was going through a question from the EDIC, which was on a patient admitted with for some surgical issue. She has post-surgery, and now presented during of post-surgery. She complained of some chest pain, and then apparently had a troponin leak of 0.1, and they had given stems of 4 answers, but it was all like whether I was unsure whether we should go for treat it as ACS or treat it as ignore the thing because of the patient the pain as described was atypical with small minor leak of troponin. So post surgery, if the troponin is elevated, so should we treat it as ACS or should we ignore the pain?
Yeah, no, normally we should never ignore a pain. So that should not be one of your answers. But always think, because this is post surgery and cardiac troponin can be increased in post surgery. So that can be a differential. And the other thing is, they usually build up this question, and then if they take you to the option, you can't thrombolize this patient if it is an ACS. I'm not sure about what the options are, but the troponin can be increased in a lot of conditions. The chart that we went through, I'll try to get back on it.
Can I ask while you are looking? Besides the acute coronary syndromes in the
Yeah.
cardiovascular domain, what other topics are important in the cardiovascular for us to know for the EDIC one?
They don't ask too much from the arrhythmia sections, like not very detailed arrhythmias. You know how you should know the ACLS protocol for your VTAC, for your VFib. That is important from your cardiovascular. You should know your ACLS by heart. That is one important thing. It will cover your arrhythmias as well. Your basic blocks, your first degree, second degree, third degree heart blocks, your basic arrhythmias, and I think I'm not sure if they ask too much about heart failure. I have not come across too many questions from heart failure. I'm not sure about that. Have you guys, what are you using for your EDIC 1 MCQs? Have you taken any subscriptions?
So I've done some of the mocks from the academy. Yeah, I haven't looked through the EDIC subscription stuff. I'm gonna look.
Because I think it's for your EDIC 1, the life in fast lane is one good place to read about ECGs and management of basic coronary related things. It's free, but it's theoretical. It's life in the fast lane. And I think go the extra mile is what we used when we gave EDIC exam not very long ago. It's less, we used it, I gave it within like last 5 years. People use it quite frequently. It's not very expensive, and it's quite good. They have good share of MCQ questions. And then, of course, do not miss on the EDIC 1 exam modules on your ESICM, because they show you how they ask questions. They are not very lengthy paragraph based, but they're also not one-liners. They are 2 or 3 line questions. So answering the question of, these are all the conditions in which the troponins can be elevated. So even after surgery, because surgery again is a muscle tear, it can lead to increase in cardiac troponin, and then ACS after surgery is also common. So it should be investigated. The pain should not be ignored, but it should be investigated. And then deciding if the patient goes on a dual antiplatelet or a further revascularization depends on your investigations. But it should not be ignored if that is one of the options.
Thank you.
Yeah. Any other questions? If you come across any questions from acute coronary care or ECG on EDIC 1 that you think we haven't covered, or if you have any kind of doubt that you think I can help with, you can always, I can give you my email ID. You can always email, and I'll try to help as quickly as I can. And I'm just trying to see how to send my email ID on the chat box. And if it helps at all, EDIC 1 is a very straightforward exam. Just be mindful, like just have a good presence of mind when you solve. It's not all knowledge, not all theory. It's very practical based exam. Very practical options. And feel free to drop in questions if you have any, and we can solve them together. Right? Anything else? I think it's goodbye then, everyone. All the best.
Thank you, ma'am, for the session.
Thank you so much. All the best, everyone.
Thank
Bye-bye.
you. Bye.
Bye.